Sir, over to you, sir.
Thank you. Good afternoon, doctors. We
Good
cordially,
afternoon.
invite you to the experience sharing program on managing PCOS and the role of melatonin. This program is brought to you by Heathrow Healthcare. Heathrow Healthcare has got 25 years of excellence and 36 state-of-art manufacturing facilities. We have got 300 plus products in our portfolio and presence in 126 plus countries. 21,000 employees globally. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching out to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, experience sharing program on managing PCOS and role of pill and melatonin. We have got
Sorry for the interruption, sir. Please, can you please mute your...
Okay.
Yeah. Sir, go ahead, sir.
Yeah. Today's program, we have got honorable speaker, Dr. Anju Sharma with us. Welcome, madam. Dr. Anju Sharma is Senior Consultant Obstetrician and Gynecologist, Director, Lotus Super Specialty Hospital, Agra, Consultant at Maitri IVF Center, MBBS, MS degree with her, and Fellowship in Reproductive Medicine. Area of interest is critical obstetric care and infertility. Future goals is promoting team approach in critical care management. Over to you, madam. I will run the slides, madam. And I will mute myself and
Hello.
Ma'am, you are not
Hello?
visible on the camera.
I am not visible.
No,
ये
no,
कैमरा
you're back.
ये
Let me see
कैमरा
your
से
camera.
zoom कर लीजिए.
Yeah, now you're visible.
yeah,
You're
you can
visible.
see the
Yes, now
slides,
I'm
na?
visible.
Yeah.
Yes,
Okay,
sir.
okay. बेटा इसको कर दो. हेलो बेटा उसको कर दो ना ये पहले वाला लाओ ना. Just a minute.
Yes, madam.
Yeah, ये वाला दे दो. Yes. So good evening.
Yeah.
I am Dr. Anju Sharma. Today I am going to speak on PCOD and role of melatonin. So PCOD is a very uh, problematic condition, and India it is prevalence is 22% up to 22.5%. So every 1 in 5 girl is suffering from PCOD, and it is much more prevalent in adolescent girls. So if we see the prevalence, it is more in South Asian countries like India, it is 22.6%, and Philippines is 20%, and Australia 15%, and it's very less in US, only 12%. So coming to the problem, it is very much high in the 20 to 29 years, that is in the reproductive age. Ladies are suffering more of PCOD in the reproductive age.
The screen is not visible, I guess, on the
Pardon?
recording. Not visible.
PCOD is a syndrome, and it is a hormonal disorder as well as a metabolic disorder also. The ovaries may develop numerous small follicles, and so we call it PCOD. Generally, ovary has one follicle, but in that gets mature and ovulate. But in PCOD, multiple like garland of follicles develop in the ovary, and none of the follicle get mature or rupture. So
Madam,
we
just 1
have,
minute, madam. Just 1 minute. Madam, you can see my slides, no?
yes, I can see your slides.
Okay, thank you.
You can see my face or not?
No. That is not. You can see the slides, it's fine. You can.
Okay.
Yeah.
So give me the next slide. Next, I have covered this. Yes. So large scale survey conducted across the India, about 16% women responded between the age of 20 to 29 years suffers from the PCOD syndrome. Next slide. So PCOD syndrome is a hormonal disorder, and ovaries may develop numerous small follicles and fluid collection, all fails to release egg. Next. So there is a condition, hyperandrogenism. PCOG gets its name from the changes in the ovary. As on ultrasound morphology, if we see the ovary has multiple follicles and all are immature, 2 to 9 mm, and more than 24 follicle per ovary. So PCOD occurs due to hormonal imbalance. There is excess of androgen, hyperandrogenism. Androgen is a male hormone. So there is always an excess of androgen, and insulin levels are also high. So there are insulin resistance, and hyperinsulinemia is the basic cause behind the PCOD. Next slide. So if we go for the risk factor, one factor is genetics. Genetics is the foremost cause that we cannot change it. Other features are like obesity, lifestyle, sedentary lifestyle, taking dietary fast foods, and low grade inflammation in the gut. These all are the major causes of PCOD, and we can correct all three causes except genetics. So obesity can be corrected, low grade gut inflammation in the gut flora can be changed, and lifestyle modification and dietary changes are very much important for correcting the PCOD. Next slide. So if we go for the symptomatology, there is a excess of male hormone, that is hyperandrogenism. This hyperandrogenism leads to amenorrhea, irregular periods, and hirsutism. Hirsutism is like excess of facial hair, and there will be alopecia, hair loss, acne, and obesity. All are because of hyperandrogenism. Some complication of PCOD. Next, when the women will be in fertile, like 20 to 30 years, there will be infertility. Most of the women with PCOD in reproductive age comes with the problem of infertility. Later on, they can develop gestational diabetes, PIH, high blood pressure, miscarriages, metabolic syndrome, and type 2 diabetes and pre-diabetes. And there are also symptoms of depression, anxiety, and eating disorders. Abnormal uterine bleeding and endometrial cancer is also a complication of PCOD because of the high level of estrogens in these patients. Next. So how to diagnose PCOD? So first and foremost is the very important to take a proper history, whether she is gaining excessive weight, whether there's appearance of facial hair, whether her periods are irregular, she is coming with the problem of infertility. Next is the pelvic examination. In pelvic examination, we can find enlarged ovaries. And third is the ultrasound. So in adolescent girl, to diagnose PCOD, we are not supposed to do a sonography. In reproductive age, we can go for sonography as a diagnostic measure, and periodic check of blood pressure, glucose tolerance, triglycerides is very important because it is a metabolic syndrome. It is a part of metabolic syndrome. Screening for depression and anxiety, and screening for obstructive sleep apnea. Next. So diagnosis of PCOD, now we use modified Rotterdam criteria, which are very important. In this, any two factors out of these three. First is the clinical or biochemical hyperandrogenism, evidence of oligo or anovulation, and PCO-like appearance on the ultrasound. Any two of the criteria are present, then we can label the patient as PCOD. Next. So main features of PCOD is irregular period, appearance of ovaries on ultrasound like PCOS, and excess of androgen. Yes, next. So our goal of treatment will depend on with problem patient is coming to us. If she is an adolescent girl, she is coming with irregular cycles or weight gain, we will treat that like regulation of cycle and correcting the insulin resistance. And again, promoting the weight loss. If she is a reproductive age women and coming for infertility, then our goal of treatment will be different. We will go for ovulation induction and treating fertility. And if she is a mature lady coming after, there's no problem of fertility, then we will treat her metabolic syndrome and decrease androgen levels. Next. So diagnostic criteria, again, we have to look for the hyperandrogenism, clinical or biochemical hyperandrogenism, oligo or anovulation, and PCOD morphology. So recommended diagnosis means total elevated or free testosterone level, and DHEA level can also be considered, and modified Galliman-Farivé score for hirsutism. It should be more than 4 to more than 8. And if she's we should look for ethnicity also. In some areas, already hairs will be more, and then we have to correct our Faraman Galloway score. Chronic or anovulation, oligomenorrhea, if the cycles are more than 35 days apart or less than 8 menses in a year. So we will look for another causes of oligomenorrhea also. And then the polycystic ovarian morphology. In this, on sonography, there will be more than 20 follicles in each ovary, and it should be volume of ovary should be more than 10 centimeter cube, and 2 to 9 follicles more than 20, based on the sonography, TVS sonography. Next. So there are 4 different phenotype in a PCO patient. We can have all the 3 criteria positive in a patient. That is phenotype A, like biochemical or clinical hyperandrogenism, chronic anovulation, and PCO appearance on the sonography. We can have phenotype B when hyperandrogenism is present or chronic anovulation is present, but ovaries are normal. And phenotype C when hyperandrogenism and PCO appearance is there. And phenotype D when there is no hyperandrogenism, only chronic anovulation and PCO-like ovaries. So while treating the patient, knowing which phenotype is there is very important. Thank you. Next slide. So while managing a PCO patient, it is a lifestyle disease. So modification of lifestyle is very, very important. We have to counsel our patient regarding healthy diet and exercise and a comfortable 8-hour sleep and sleeping time, sleeping hygiene, all are very, very important. Second come the medications. So there are so many different medications are available. I will discuss next in next slides. And third is the dietary supplements. So gut biome is very important. Taking healthy diet is very important. Removing fast food from the diet, and all of these the part of PCOS. As the PCOS cause is also multiple, so treatment should we all take all the holistic approach, not a single approach. Next. So while managing the PCOD patient, contraceptive OC pills has very important role. If the patient has come for cycle regulation, she doesn't want fertility, we will keep the patient on OC pills for few cycles, uh, and 1 tablet per day. Adverse effect may come in the form of breast tenderness, weight gain, and some risk of thromboembolism. So we'll choose our patient properly for OC pills. If patient is come for infertility, we can put the patient on clomiphene ovulation induction, 50 to 150 milligram per day for 5 days. We all know. And side effect is hot flushes, nausea, and headache, and blood vision, and multiple gestation. If the patient has not achieved pregnancy with clomiphene and letrozole, then we can go for gonadotrophins. For ovulation induction, doses depend on the patient's response. And in this also, we have to take care of hyperstimulation and multiple pregnancy. Breast tenderness is also there. And third is the metformin. Metformin is a very important drug, and it decreases the hyperinsulinemia and androgen excess. It is given in the 500 milligram BD with food starting dose. Then we can increase up to 850 milligram per day TID with food. Again, nausea, vomiting, gut symptoms are there, diarrhea and neuralgia, and take care of lactic acidosis also in some cases, very rare. In spironolactone, it is aldactone, anti-estrogen, anti-androgen, and it is used for hirsutism and acne. And 100 to 200 milligram per day, and it may cause hypotension and hyperkalemia. And next is the pioglitazone and rosiglitazone. It is also a drug for hyperinsulinemia and androgen excess. And we don't use much these drugs. It can cause weight gain, edema, and increase cholesterol levels with rosiglitazone. Next. So now we have myoinositol, and it is a nutraceuticals. It is not a drug, it is it is supplementation. So myoinositol has a very great role in PCO patient. In PCO patient, studies shows five-fold decrease in myoinositol in the ovaries. And follicular development is very important. Reduced level of myoinositol in the ovaries will decrease the quality of ovum. Combined dose of myoinositol and dicarbonate is administered. It is very beneficial in PCO patient and its ratio should be 40:1. Myoinositol should be given in 40 times and dicarbonate in 1 ratio. So ratio is very important and long term it has to be given up to 3 months to 6 months. In 3 months it will improve the ovulation and for hyperandrogenism system symptoms at least 6 months should be given. Next. So if we do the study of myoinositol level in PCO patient, the inositol level is less in patient's ovary as well as in the plasma. 5-time increase. So ideal physiological dose of myoinositol versus dicarbonate is 40:1. This ratio is very, very important to increase the insulin sensitivity. Myoinositol levels are high in the ovaries, while DCI levels are in the peripheral tissues. So we have to take a drug, select the drug in which the ratio is given in a proper ratio. Thank you. Next. So how does it act? So myoinositol will improve the insulin sensitivity. It will decrease the insulin resistance. It will improve the glucose uptake and it will decrease the free and serum testosterone levels, provide good quality oocytes and restores the menstruation and normal ovulation and improves the pregnancy rate. It is well clinical evidence is there. Next. Myoinositol and decarbonate therapy in physiological plasma ratio should be considered for the first line therapy in PCOS. Because it is according to international studies. And International IVI Congress reported this study. Next. Chromium chloride, folic acid and vitamin D. So chromium chloride is a form of trace mineral and it is very important for glucose metabolism and insulin sensitivity. And folic acid, we all know, it manages infertility, ovulation problem, and in all the women's. And vitamin D is have a very key role in PCOS patients and managing infertility in pregnant patients. All the three molecules we use always in patient with infertility and fatigue and all these health issues. Next. Now comes to melatonin. Melatonin is the hormone secreted by pineal gland and it is very important for our circadian rhythm. It's a concentration of melatonin in preovulatory follicle is lower in women with PCOS. So melatonin support nuclear maturation in oocyte. So melatonin administration may be very, very useful in IVF and improve the quality of outcome in PCO patient. Therefore, melatonin may provide improvement to oocyte quality and increase the pregnancy rate. So melatonin is a hormone that induces a sleep. Next. So I have gone through this. Melatonin supports the nuclear maturation in oocyte and its administration is very, very helpful in PCOS patient for fertility. Next. So administration of melatonin alone or in combination with other drug in PCOS patients. It increases the intrafollicular melatonin concentration, reduces the intrafollicular oxidative stress, and also increases the fertilization and pregnancy rate. Melatonin is also improve the production of progesterone from corpus luteum. Melatonin can also regulate the synthesis of GnRH through its receptor on the granulosa cells, increasing the GnRH receptor expression and sustaining the corpus luteum to maintain progesterone secretion. So in infertility patient, if we give melatonin, it is very important and improves the outcome of IVF also. Next, follicular fluid contain lesser melatonin levels compared to healthy condition in PCOD patients. So melatonin administration in PCO patient significantly affect the body characteristic, including reduced body weight, reduced BMI, and intra-abdominal fat. During the ovulatory process, reactive oxygen species are produced within the follicles. For this reason, the scavenging activity of melatonin plays an important role during ovulation. Intrafollicular melatonin concentration was considerably lower in PCOS patients, giving rise to anovulation and poor oocyte quality in these patients. So melatonin is a very important role. And we all know folic acid in PCOS is very important. Accumulating studies have reported various role of folic acid in female reproduction. So any patient is coming with infertility, we start folic acid in all the patients. Next. Folate is very important for oocyte quality, maturation, implantation, and placentation. And after even in babies, folic acid is very important to prevent congenital anomalies like spina bifida and all. So effect of supplementation with minoxidil plus melatonin. It is a very great combination. In present study, we aim to evaluate the pregnancy outcome after administration of MI along with melatonin. The women who failed to conceive in previous IVF cycles or poor oocyte quality. Conclusion is that the treatment with minoxidil and melatonin improves the ovarian stimulation protocols and pregnancy outcome in infertile women with poor oocyte qualities. Next. The effect of treatment of minoxidil plus folic acid plus melatonin in comparison with the treatment with minoxidil plus folic acid. Whenever we are adding melatonin with minoxidil and folic acid, the melatonin ameliorates the activity of minoxidil and folic acid, and by improving the oocyte quality and pregnancy outcome in the women with a low oocyte quality history. So this study also support the role of melatonin. So we should add melatonin with minoxidil and folic acid. Next, the effectiveness and tolerability and safety of a compound based on DCI, myoinositol, melatonin, folic acid, and vitamin D. It is like सोने पे सुहागा, आपने सब कुछ ही दे दिया जो चाहिए पेशेंट को, and उसमें विटामिन डी भी ऐड कर दिया. That is a complete solution. So to combine inositol, melatonin, folic acid, and vitamin D exhibit potential as a efficacious approach for managing menstrual disorder while maintaining a commendable safety profile. Additional investigation in the long-term efficacy and safety of the formulation are warranted, although initial results holds promises. Next.
So much, madam.
Thank you.
Thank you so much.
Yeah.
We'll come to some of the questions which have commonly people ask. What is the place of nutraceutical in management of PCOS? In fact, in which type of PCOS you would prefer nutraceuticals?
I think we will use in all PCOS because we have different type of
Correct.
nutraceuticals, and it is very important. One factor is that हम patient को दे सकते हैं, and if somehow she managed to miss one or two tablets, there is no problem. Like
Correct.
if you are giving OC pills, she has to take it regularly. While in nutraceuticals, she can miss one or two pills, no problem.
Okay.
And it is easy to take. It is like vitamins and simple food articles.
Correct.
We can counsel the patient also. We can give it in a form of powder also.
Okay.
So it gives a less burden of medication on the patient.
Okay. Then, madam, would you use these nutraceuticals straight away first line, or you use after some time, after initial trial with the drug?
But I will start with the nutraceutical. It depends on the patient history.
Patient, correct.
If she is ready, if she is come for infertility, along with nutraceuticals, I will give ovulation induction also, and not
correct.
keeping all this. We have to make it fast also. Patient
Absolutely.
cannot wait for 3 to 6 months.
That's correct. That's correct. That's correct.
Yeah.
In your opinion, what is your opinion or experience about use of melatonin in PCOS?
But melatonin is a very important hormone. It is secreted by pineal gland.
Yes.
And it is maintaining our circadian rhythm. And that is very important, because if we are not sleeping properly, It will cause our stress will increase, our hormones will get disbalanced. If you are adding melatonin, that will give you peaceful sleep pattern and will increase our hormones, and it will act as an antioxidant.
Antioxidant.
Yeah, and anti-inflammatory also.
Correct.
Yeah.
What is your experience about combining inositols with melatonin? I mean, you have used there are so many products available, inositols
Yes,
with
yes.
melatonin.
Yeah. It is a very good combination. At least 3 months I will give.
Yes.
At
And
least
you
3 months.
and
Yeah.
you give once a day.
Yeah.
Yeah. And generally, I mean, you would prefer it in both type of PCOS depending on their symptoms.
Pardon?
You will prefer it in both type of in all types of PCOS
Yes, yes,
depending on the
all type
symptom.
of patients. It is it will correct your insulin resistance also, na.
Correct, correct,
So
correct.
basic metabolism, basic defect will be corrected.
That's right, for at least
If
3 months,
you are
you said.
correcting the baseline problem, na, hyperinsulinemia should be corrected. So
Correct,
that
correct.
is very inositol is very effective in that.
Absolutely.
Yeah.
And metformin, madam, which type of PCOS you prefer in all PCOS or I mean related to
No, I will
hyperglycemia?
choose. I will like to choose the
Ah,
patient. If there is
exactly.
like patient is obese and
Obese.
patient is having some symptoms of pre-diabetics
Ha
and
ha
there is a
ha
history of diabetes in her
ha
family,
ha
I
ha.
will keep her on metformin. And
Okay.
metformin to be started with a minimum dose. Like
Yeah.
I will
500.
start with 500
Hmm.
with food OD.
Okay. Okay.
Then I will increase it. So patient can take it. Compatibility aa jaye patient ki. Otherwise, she will have lots of bowel symptoms
Yeah, yeah.
and she will
Metformin
drop
has
them.
got yeah.
And I
Metformin has
have to
got the
explain
yeah.
the patient, I am not giving it because of diabetes.
Yes,
It is
that's
being used
important.
in differently also.
Yeah,
Otherwise,
because this
chemist
people
will
correct, correct.
suggest him.
क्या diabetes हो गया क्या?
Yes, yes. That is a great problem. तो
Yeah,
पहले से ही बताना पड़ता है कि you are not
absolutely.
diabetic. It is given in PCOS also.
Absolutely.
Yeah.
Metformin is a wonderful drug. It's used in so
Yeah,
many
it is a
conditions.
wonderful
Oh,
drug.
yeah.
It is a cheap drug and
Yeah.
it is easily available drug.
Correct, correct, correct. And generally well tolerated.
Yeah, it is being tolerated. If you
Yeah.
explain the patient, take it with
Correct,
food,
correct, correct.
patient will tolerate it.
Do you prescribe metformin along with nutraceuticals, or you take a break with nutraceuticals, prescribe metformin, or commonly
No, no,
together?
I will give along with
Along
nutraceuticals.
with.
I will prefer to give with along because आपका नाम भी वो हो जाता है, hide
Hmm.
हो जाता है.
Okay.
Yeah. And palatability भी patient की बढ़ जाती है.
Now, your opinion on a combination. There are so many combinations available of metformin with nutraceutical. Would you prefer that, or you would prefer separate prescriptions? Because then you can
Again,
alter.
depends.
You
If
can alter
patient is
the.
more toward pre-diabetics or obese, then I
Oh,
will give metformin plain in
oh,
higher doses. Because
okay.
if you go for combination, there will be less dose.
Yes, yes, yes. And
Yeah.
then you cannot alter the dose of one
Yes,
ingredient
we cannot alter the dose
separately
itself.
when you.
So then
You
I will start separately. If it is normal, lean and thin patient, we can give in combination also.
combine, correct. So
Yes.
there is no hard and fast rule depending on patient's condition.
Yes,
Sometimes you may
yes.
be required to give metformin twice a day, whereas
We
nutraceutical
have
you
to
may
tailor make these things
yes, 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 correct,
according to patient.
correct, correct, correct. And what is take-home message from you to the audience on this nutraceuticals, melatonin
Yeah.
combinations,
Okay.
inositol?
My take home message is to the all audience is that PCOD is a very much prevalent disease. So
Correct,
first of foremost, we have to take out the fear of the disease. Every
absolutely.
girl is coming, अरे मैम पीसीओ हो गया क्या होगा आगे लाइफ में कैसे होगा तो let them give some tips according to the lifestyle modification. If you change these patterns in your life, you will not develop PCOD in full fledged. Though genetics is there, but still you can prevent the PCOD. And we'll prescribe them nutraceuticals along with metformin. Starting the treatment early will prevent their metabolic syndrome.
Correct,
We
correct.
were not only exercise will not suffice, only diet change will not suffice. We have to attack all the three sides.
Including
Yeah.
nutraceuticals, yes.
Yes, nutraceuticals plus diet plus exercise
Correct.
and plus counseling. And they have lot of stress of study. All the time they are studying from
Yeah,
night.
yeah, yeah.
They start studying from 9, 10 o'clock till 2 o'clock.
Yes,
I
unfortunately,
advise
yes.
them study from morning 5 o'clock till 9.
Hmm. Correct.
That will be more
I
physiological.
mean, they have to adjust their timings about
Yeah.
everything. Yes, that's
Night
exactly what
study is a fashion कि भाई हम एगी खाएंगे और स्टडी करेंगे चाय पियेंगे तो दैट विल इंक्रीज योर ऑल थिंग्स एंड
Correct,
उसके
correct,
बाद
correct.
सुबह मॉर्निंग 12 बजे तक उठेंगे तो आपका सारा टाइम चला गया ना
Absolutely.
इम्पोर्टेंट है
And
Yeah.
physiological secretions of hormones also get
Yes.
affected na, with this.
सारा मेलाटोनिन सिक्रीशन circadian
Yes.
rhythm all will be
Yes,
disturbed
going for a toss.
and your study hours will also be less.
Correct.
If you study in night and you struggle to wake up.
Barabar.
So these my advice to young girls and in patients seeking fertility, they should come earlier.
Correct.
अब 35 के बाद आप start करेंगे treatment, then it will be too late. So
Correct.
if you are getting married late, then come for fertility earlier. Thank you.
Thank you so much, madam.
Thank you. Thank you. A lot of disturbance because of my laptop is not working.
That is okay,
Yeah.
madam. That is okay.
Okay.
The
Thank you
more
so much.
the more this thing we have technology, the more disturbance will be. No problem.
Yeah.
It was a good session.
Why
Good
not?
insights
I
on
don't know.
yes. Good insights on PCOS and role of melatonin and
Mhm.
combinations.
Next time I will
Nice.
arrange all the things.
Yeah, no
I don't know how.
problem. I mean, what
Thank you.
your inputs are more important to the audience, madam, because
Yes, yes.
किताबों में कुछ भी लिखा है तो अपने डॉक्टर का experience
नहीं
experience
नहीं
ना finally.
practical experience is much more
Yes,
important.
yes. Thanks so much. Thanks for taking time. Thanks all the doctors who
Thank
took time and attended this in the afternoon. Thanks
Thank
IT
you.
team Nagadevi. Thanks PMT Manisha. And thanks all the sales people for super coordination.